Well, hello and welcome to this very special conversation. Today, I am talking with my friend, Dr. Jessica Ritch, who is a board certified, fellowship trained, minimally invasive gynecologist practicing in Florida, as well as the host of the amazing podcast that everyone should be listening to called Enriched Menopause. If you are a woman or you live with a woman, this is something that you need more information on, and I definitely want you to go check it out. So links will be below. Dr. Jessica Ritch, welcome to the show. I'm so pleased that you're here with me today.
Oh, thank you so much, Megan. I'm really excited to be here and to talk with you. I think this is going to be great.
Yeah, perfect. So let's talk a little bit about, kind of your work and how you got started. So you provide medical care for women who are experiencing issues that commonly arise during perimenopause and menopause, but not just during those times, of course, things like treating fibroids and urinary incontinence. Tell us how you got involved with that area of medicine.
hmm Well, I was always interested in taking care of women. I grew up as a female athlete and just like loved those bonds. And when I was going through medical school, I just really enjoyed the OBGYN rotation where I was, helping women with their issues. I could really relate to what everybody was going through and kind of working through all of those things. So that led me to do my residency in obstetrics and gynecology. And during that, I had a great time in so many areas. I loved, delivering babies. I loved doing surgery. I loved like a lot of the parts of that. But what I really liked focusing on is really the problems that I felt like were under addressed in our
Mhm.
system. So generally, if you're a woman who had cancer, you're going to get, really good care and research. If you were pregnant, you're going to get really good care. And a lot of this other stuff that really affects most women in our day-to-day lives, like bleeding and pain and incontinence, all these things were kind of getting brushed aside a lot because it's like it's just not important, you can just deal with it. And
Yeah.
so that's what led me to do a fellowship in minimally invasive gynecology, which I did for 2 years, which really focuses on a lot of these issues. So, endometriosis, fibroids, pelvic pain, urinary incontinence, like all of those things. So, I did my fellowship and then I've been practicing. I've been out of fellowship for, wow, almost a decade now. Makes me feel like I'm a little bit older than I thought, but almost a decade now. And so, really focusing on these gynecologic issues that aren't cancer, that aren't pregnancy. I do a lot of surgery, I do a lot of pelvic floor physical therapy. I mean, I have felt physical therapists that I work with, and then just a lot of different types of ways to help women address these issues. And along the way, a lot of the menopause stuff kind of kept creeping in. And I would say it was one of those areas, like hormones were kind of like my least favorite thing always in gynecology. Just they're complicated and they fluctuate, and different values mean different things for different people at different times of the cycle. But, as I started getting into perimenopause myself, I'm 43. And yes, you can be 43 or even younger and be in perimenopause. And I saw my friends going through it and I saw my family and my patients going through it. I was like, well, let me, really spend a little bit more time seeing what's going on in this and just helping out. And so I did a lot of listening, I did a lot of research, and then I decided to start my podcast, which is both sharing what I've learned and also an exploration into these kind of many different areas of perimenopause. So I learned just as much from it as I hope other people do as well.
Yeah. Yeah. Um, I've heard you talk about it on the podcast, and I've heard, some of my other, OBGYN colleagues talk about it. And it's interesting because I think a lot of people are surprised by how little we learn during our training about
hmm
menopause. Menopause specifically, not at all perimenopause. I mean, I don't think I heard that term until later, which is crazy to me now. But it's this.
Even in OBGYN residency,
Right,
like we
right. I
would
mean, that's
have a
the thing. Like,
lecture once a
I'm family
year.
medicine, right? So I assumed you guys were getting all the information.
Oh,
And I've learned it's not so. And that drives me
mhm.
crazy because I was just like, well, if
Yeah.
I don't know it and you don't know it, how are we supposed to take care of women? So I'm really grateful that people like you are deciding that's not okay. And getting out there and sharing information. And yes, like learning as we go, right? but sharing that information with other people. I've told so many of my patients this, that your episode where you talk about hormones, which I think is episode 2, is the
Mm-hmm.
best lecture that I, as a physician, have ever heard about
Oh,
hormones, and like why, why we don't always want to check them, and like what the levels mean, and how it's all different in the cycle. And you and I are both about the same age, and we also trained during the time where menopause hormone therapy, or hormone replacement therapy as it used to be called, was evil, right? Everybody was being
mhm.
taken off of it. All these women, missed their hormones. And I know my mom was going through that time, and she got off hormones and was miserable. And she used to call me all the time and be like, I just stepped down again. And, she was just so angry about it.
My mom just refused.
Yeah, yeah. So, it's just so important. So I'm so grateful that you are out there kind of sharing this information, and so glad that we get a chance to talk about kind of our shared interests, and kind of dive into conversation about metabolism hormones and perimenopause, menopause hormones,
Mm,
because there's so much overlap.
definitely.
Yeah, yeah. So I'll describe a little bit. I mean, certainly as a family medicine physician for, I don't know, 13 years now, I guess, out of training. And then more recently as an obesity medicine physician, I've seen women come to me for years, often in their early 40s, sometimes late 30s, sometimes later, right? Complaining of weight gain, brain fog, joint pains. They don't feel like themselves, right? Maybe they don't feel like sex. Maybe things feel a little bit more uncomfortable. They're still having periods. So they think, well, I can't, my hormones must be fine. And yet they're also being often pushed by their friends, like, go get your hormones checked. It's got to be your hormones, or maybe you have ADHD. That's the newer thing, right?
Hmm.
So talk to us a little bit about what we don't know about perimenopause, and like where that conversation needs to come in, when we're
Hmm.
thinking about, yeah, this is probably some of those hormones starting to change.
Yeah. So it's such a complex area. And I think it's one of those that everybody thinks, though, like nobody knows what is happening to them, or like they don't think about it. So
And we
average
think
age
it's
of
just us.
menopause. Yeah, right, exactly. And everybody's like, wait, I'm too young for that. Even when I'm talking to women who are like mid 50s and who are on the later side of menopause, they're like, wait a minute, I'm too young for that. Because we see menopause, unfortunately, as this like transition to like old age, right? Which it totally isn't. Like it's very midlife for us now, and it's a transition just like as dramatic as puberty is for many of us, but we don't really look at it in the same way. We don't really look at it in that like new possibilities kind of way. It seems like it's like this decline, and I
Shut the
really think we
doors.
should change that perspective. And luckily so many more people are talking about it. Oprah and Michelle Obama are talking about it now, which really helps quite a bit. But basically, so menopause is the distinct period of time when somebody has been without a period for 1 year. Now, of course, that's harder to determine if somebody's had like a hysterectomy or an ablation, but in general, regular menstruating person without a period for 1 year, when they hit that date, that's when they hit menopause. Everything after that is postmenopause. Everything kind of leading up to and around that time is perimenopause. And so average age of that is 51, but perimenopause on average occurs for like 4 to 5 years up to that, and
Mm,
can even be as long as 10 years, which means that if average is 51, that means some women are actually hitting menopause in their mid to late 40s, some into their mid 50s, and that perimenopause can extend as early as the mid 30s. And what's happening in perimenopause, what we do know about is that basically, we're born as women with all of the eggs that we're going to have throughout our life. So men keep making sperm, we don't. We're born as babies with all of the eggs that we're going to have. And those eggs over time, we have less and less of them. Some of them that get, ovulated and used, and some of them that just like over time kind of degrade and get less quality. So over time our ovaries really can't produce the estrogen and progesterone and testosterone that they were producing before. So Of course, the adrenal glands play a role in this, and we'll talk more about that probably in your portion, but I'm going to leave them out for the moment, and talk about basically it's just this hormone from the pituitary gland in our brains called FSH, or follicle stimulating hormone, which is in this like feedback loop with the ovaries. And what happens as we go through our normal menstrual cycle is that the estrogen and progesterone go down after like ovulation, after our menstrual cycle. The FSH kind of revs up. Estrogen and progesterone usually go up, estrogen first, and then that kicks in ovulation, and progesterone then afterwards. We're not going to get into all the details of that, but basically, after a while, as our ovaries get older and our eggs get poorer quality and less of them, they don't really respond as much to the FSH. So our pituitary gland in our brain keeps revving up the FSH to try to get the ovaries to respond. And in perimenopause, they will eventually respond, and sometimes dramatically. So I do see a lot of women who come to see me. They're like, my estrogen is so high, I must have a tumor somewhere. And like we follow it and it goes down, and it's like, no, this is perimenopause. But it will respond, and then you can have bleeding and have irregular cycles. But the estrogen kind of is having issues, and then the progesterone is also having issues. So you're not ovulating on a regular basis. That FSH and estrogen is going to start to fluctuate, and the periods are going to start to get irregular. Usually they'll start to shorten first, meaning that the time from one period to the next is going to get shorter. So if you had like a typical 28-day cycle, it may be more like 24 days, and however that. And then eventually they start to get longer, and then it just goes all over the place. Like the hormones are going up and down, trying to like stimulate each other, and then it just gets wacky. Like you may go 6 months without a period, then you may have one every 2 weeks for 2 months. They may be heavy, they may be light. It's all over the place. When you have these wild fluctuations in your periods, it really affects your body in so many ways. So, what we think about most is the hot flushes, because the temperature sensors in our brain are kind of like right next to those estrogen receptors, and they're really sensitive to estrogen. So, suddenly, even the smallest temperature changes makes us feel like we're so hot and we need to like sweat and cool our bodies down. So, that's where the hot flushes come in. But it's also, yes, mood fluctuations and weight gain, which is typically going to be that central fat around the abdominal muscles, or sorry, not muscles, but abdominal organs, which is a much more dangerous type of fat. And I'm sure you're going to get into that a little bit later, but also just makes women feel terrible. Like suddenly, like I'm gaining all this weight in my midsection. And then joint pains, headaches, body aches, skin changes, hair changes, acne, like sometimes like that puberty time. So there's like all of this stuff, brain fog. Like really makes people feel like they're going crazy, and they're like, I'm just not myself anymore. And it also tends to like correlate with other things going on, like maybe elderly parents having issues, or you're raising young kids, or maybe they're going off to college, or there tends to be relationship issues that go along this time, particularly because of changes in libido and changes in mood. So all of this stuff kind of piles on, and it can be really easy to get lost in it, to feel like, you're not yourself anymore, and that everything is like, lost and gone forever.
Yeah.
Now, the good side about this is that it's temporary. Like most of the bad symptoms are going to happen around that time of perimenopause. And then, within a few years, typically of the periods ending, a lot of it just gets better, which is great. Not everything gets better. But it's really a challenge. And I think so many women are told you're too young for this, or they think they're too young for this. They're looking for every other thing under the sun. And it's really this fluctuation.
Yeah. Well, and as you point out, right, the estrogen and progesterone, like all of those hormones are changing every day. That always happens to us, right, when we're in our regular menstrual cycle, but we aren't usually checking them every single day, right?
Mm-hmm.
But somebody comes in and they're like, oh my, I have to go get my hormones checked, right? And then sometimes people will come to me with, these big panels of hormones that I've never heard of, oh, and this is high and this is low. And I'm like, yeah, and if we checked it the next day, it might be the opposite, right? Because there is
Mm-hmm.
so much fluctuations. I think it's so important for people to know that, those blood levels are not always that helpful compared to us really looking at that big picture, right? And trying to make sure we're not missing other things, right? But
Mm-hmm.
just sort of normalizing the experience, deciding what's appropriate to test and do, and then deciding on how we're going to help,
Mhm.
right?
Exactly. And you make a great point about the hormones, because that's the thing. People will come in, they'll be like, I'm feeling hormonal, which basically means like I'm feeling terrible and not like myself, or I'm
Right.
gaining weight, or have acne or mood fluctuations. Like, I need a hormone panel, and they want me to, like, find something and treat that specific
Right.
something,
Right.
which there are people out there who do that. It's not really what I think makes sense. But basically, I do recommend that we check some hormone levels, because we want to rule out certain things. So we want to evaluate for things like PCOS and thyroid dysfunction, and we want to look at cortisol levels, and we want to look at all of this. And then sometimes the hormones will give us some clue that you're in perimenopause, but because there is that up and down, they may be totally normal. So most often when I send out a hormone panel, it's normal. And the thing is, there's a broad range of normal. It depends on where you're at in your cycle, what things are going to be. And that can be
And
hard
you
to
may not
know when
be
things
able
are
to
really
tell,
fluctuating.
right?
Exactly.
Yeah.
Exactly. So
Yeah.
most often it's going to be normal. And I don't want to treat somebody based on a level of hormone, because it is going to change from day to day. And because what feels good to me is going to be different than what feels good to you. So we
Mhm.
treat the symptoms, we treat kind of the whole person and what's bothering them.
Yeah. And I love the analogy, and I've heard you talk about this before, that, it's a major shift, not unlike puberty, right? Puberty transitioning from a child body to an adult body. And this time, and at that time in our lives, most of us don't have very many responsibilities. We're going to school, we're doing sort of normal kid things. And here we are in this other phase. We might have a lot of the same things, right? Our brains are a little dumb when we're going through puberty, right? Because they're changing, right? So
Yeah.
we can call that fog if we want to, right? We probably don't have the joint pains, but we do have a lot of period fluctuations in both puberty and perimenopause. We might have acne, we might have a lot of different things going on in our bodies, but at this different phase, right, with perimenopause and menopause, we often have a lot more responsibilities, a lot more
Hmm.
stresses and worries.
Hmm.
It's just a much more different time of life to be going through those physiologic hormone changes. I think it's a great way to sort of think about it, because most of us have forgotten being in the thick
Hmm.
of puberty,
Yeah.
right? With things
Hmm.
happening to our bodies, our moods were all over the place, our thinking wasn't as good. And now we have kind of this is, this bookended, experience on the other
Hmm.
side, but with so much more going on in our lives.
Right, right. And puberty, even though it's like, yeah, it's terrible to be in the thick of it, it's terrible to be a parent of somebody in the thick of it too. But you kind of like expect it. You know that it's like a limited time
Yeah,
period. And even though it can be a fairly long transition, it's still like generally a shorter transition than menopause is. And it's something that's more like understood and more talked about along the way. And
and
yes,
it's
we do
both
have a lot going
genders.
on.
It
Hmm.
it's it hits everybody. Yeah.
Mhm. Yeah, and we do have a lot more going on at this time. And I also find I was listening actually a post. I don't know if you know Dr. Mary Claire Haber. She did the Galveston diet. She's great. So she had a post the other day about how we always talk about these different stressors in our life, because there are a lot more stressors. But at the same time, it's not just that. She was kind of questioning, it's also that, like, we've managed stress before. We have a lot of stressors in our lives in general, but that resilience, or that like
Mhm.
buffer that we have to cope with things, is a lot more narrow. Just like our temperature regulation is a lot more narrow in perimenopause and giving us our hot flushes, our sort of like mood regulation or our stress regulation is also a lot more narrow that time, that like smaller things can like tip us over that edge.
Yeah, yeah, perfect. And so we've talked about it, just a little bit, but yeah, thinking about some of those, metabolic changes that are also starting to happen. Now, certainly as we get older, we're more likely to have different metabolic challenges that affect us more, such as insulin resistance, such as prediabetes and diabetes. Cholesterol is affecting us in a different way. What is the connection in your understanding of all those hormones sort of going on at the same time between sort of perimenopause, menopause, and metabolic changes, and maybe we can touch a little bit on PCOS, right? Because that also is kind of influencing that axis of things.
Yeah, so definitely we see this most commonly with PCOS or polycystic ovarian syndrome, which is one of those kind of bad terms in medicine, but basically,
It's probably 14 different conditions, right?
yeah. And it really has nothing to do with polycystic ovaries at all. But basically, it's a condition where there is some androgen excess. So androgens are kind of the more male type hormones. So testosterone, DHEA, which is our precursor hormone. There can be a polycystic appearance to the ovaries, although again, not really cyst. And somebody's usually not ovulating on a regular basis, so not having regular hormones. And that can cause a lot of issues, but one of them is insulin resistance. So we know that hormones play a role in insulin resistance. Basically, what that is our cell's ability to take in glucose, which we get from our food, and to use it for energy. So when we can't do that well, we get like spikes in glucose, which again can lead to diabetes and weight issues. So we know that hormones affect this. We also know that that happens during pregnancy. People are much more likely to have diabetes during pregnancy with all the hormonal changes. So we don't really know the exact of why, but it happens in perimenopause and menopause too. And that tends to be why we see more of that weight gain around the abdomen, why people are seeing a little bit more insulin resistance and diabetes and weight issues at that time as well.
Yeah. So it seems like kind of a double hit. And yeah, we don't always understand the reasons why exactly they're related. But you were talking before about, kind of the feedback loop, right, with our FSH and our our estrogen and progesterone. We've got this glucose insulin feedback loop, right? And so as our bodies are starting to have metabolic difficulty with tolerating, sugars and starches in our diet, that comes through the bloodstream, insulin is supposed to be released from the pancreas, right? It's supposed to travel to the muscles and kind of unlock the door for sugar to go into the muscles. But with insulin resistance, it's that same thing where the muscles are sort of not they're making like the lock is sticky, right? They're like, we don't want more sugar in here. And what the pancreas does is it responds and kicks out more insulin, right? So we see high insulin levels even if the blood sugars are normal. And that's also a condition that's often going on for years before we get this diagnosis of prediabetes or diabetes. And it's another area, right, where medicine has sort of ignored that or not understood that well for a long time, but it's a common cause of a lot of the weight gain that we start to see at that time. And people will have normal blood sugars. They might even have low normal blood sugars because they've got so much insulin going around. But that insulin is telling them to be more hungry and to store more body fat, especially body fat around the middle. So we're seeing that rise, and then we throw a little cortisol, a little stress in there, right? And just kind of ups the ante on all of that.
Right. So you're adding in the stress, and then you're also adding in menopause decrease in your muscle mass too, which is another issue because of course muscles are really driving a lot of the metabolism that we have, and muscle mass decreases in menopause. So what I hear all the time, and I think it sounds like you hear this too, is that I have people who come to see me and they're like, look, I'm doing all of the same things. I'm eating the same. I maybe never exercised in my life, or maybe I'm doing the same
or maybe I'm doing the
exercise.
same as I used to do.
Yeah. And I'm gaining weight. And particularly I'm gaining around the midsection. So how do you approach people with that?
Yeah. I mean, I think the first thing that I am doing, after we kind of, are taking that history, right, getting all the information, have you always struggled with your weight, or is this new, right? A lot of people had a lot of weight gain during the pandemic, but some of those people struggled with their weight for a long time and others didn't, right? So kind of finding out, like, tell me all the things that are going on, right? That deep dive history. And then I am checking insulin levels and blood sugar levels and kind of screening for all those issues. And I'll tell you, it really wasn't something that I learned in either my family medicine or my obesity medicine training, to be honest, that we need to be paying more attention to the fasting insulin level. Because when the fasting insulin level is high, and when the ratio between the fasting insulin and the glucose level is high, that tells me that that person is in insulin resistance. And we have a few other ways that we can check. Glucose tolerance tests like you would do during pregnancy can also, kind of give me that sense of what's going on when combined with the fasting insulin. But, when I see that pattern, I, regardless of what the person is doing or not doing about their nutrition habits and their physical activity, I know that their body's metabolism is starting to work against them, right? Because as that insulin level goes high, they're hungrier, so it's harder to stay with the same nutrition. And their body's putting on weight, and often people are just feeling stuck. They're like, this always used to work for me before. I would cut back on things. There's also a phenomenon that happens when people have yo-yoed up and down that unrelated to the insulin issue. Every time we drop body weight, our calorie requirement to stay at that lower body weight goes down, and our hunger hormone, which is called ghrelin, goes up. And so again, every time we drop the weight, we're more hungry, and we have to eat less to maintain that lower body weight. So there's a lot of ways in our metabolism. It's awful, right? And I remember learning that and feeling so defeated. I was like, what else? What are we going to do? But when someone's coming to me with those challenges and they've been taking all the steps, sometimes I'm connecting them with some of the wonderful nutritionists I work with, really kind of making sure that things are dialed in that way. We're always talking about nutrition and activity and sleep and stress. But also that's where medications start to come in, right? Because we are fighting that biology. We are fighting that underlying hormone axis that is working against you. There's a lot of theories on why that might happen. It might be, kind of one of the most popular reasons is we think, this is the primitive body trying to protect against famine, right? It was concerned that we would run out of food at times, right? And so we needed to, kind of slow down our metabolism when our weight dropped, so that it didn't, we didn't continue to lose weight, right? So the body has these metabolic mechanisms to maintain that higher body weight and to emphasize that and store extra weight. And it's not a good system in today's food environment, where most of us will never experience famine for sure, but most of us, also rarely are without food for, a couple of hours or more. Food is just kind of everywhere. And so all of that together, is kind of going on.
Yeah, definitely our bodies were developed for a different world than we're living in now.
Yeah.
And yeah, with our bodies having all of these changes during perimenopause and menopause, that's what I tell people, like, well, you can't do the same thing and expect the same results because your body's
It's changed.
changing.
It's changed inside without your permission.
Yeah. I'd
Yeah.
love to hear a little bit more about your approach to medications, because that's something that, of course, is in the media a lot, especially with Ozempic and
Yeah.
Wegovy and like all of these,
Yeah.
newer medications that some people are having great success with. It's not something that I prescribe. It's not really part of my practice,
Yeah.
but people are asking me about it all the
All
time.
the
So I'd
time.
love to
Yeah.
hear your approach and how you look at those.
Yeah. Yeah, so we call those medications anti-obesity medications, and it's kind of, I don't know, a silly term, but I want to make a distinction between diet pills. So diet pills, I think of, kind of things that people take over the counter, they're often caffeine or some other kind of stimulants. They often contain weird chemicals and sometimes dangerous chemicals, that are trying to get somebody to cut their metabolism or decrease their hunger real fast, and it's considered this short-term strategy. When we are talking about anti-obesity medications, we are talking about long-term treatment of those metabolic issues and or body weight. And it's really, in my mind, about focusing on improving health, right? We want to prevent diabetes, we want to prevent heart disease, we want to prevent liver inflammation, stress on joints, kind of all of these really important things, so that we feel good as we are living our lives and getting older, because of course time just moves in one direction.
Mhm.
Um, so I'd say that there are a variety of anti-obesity medications on the market. And there's probably three that I use most commonly. The first being metformin, which would be a medication that you'd be pretty familiar with, I imagine. So
Mhm.
metformin is a diabetes medication. It's quite an old medicine. It's very cheap. It's generally well tolerated. We go really slowly with it because it can cause some stomach upset, some diarrhea, things like that. But it is a great tool to use when we are trying to overcome that insulin resistance and help people's efforts be successful. So the person
Mhm.
who's like doing all the things, I'm eating really clean, I'm not taking in too much junk, too much sugar, I'm exercising, but nothing is budging. I reach for that fairly often, and I push it to a high dose because a lot of people are on a fairly low dose, which works when we're treating blood sugars and diabetes, but it doesn't tend to overcome the insulin resistance weight gain pattern. And so pushing up to 1,000 milligrams twice daily is
Mhm.
kind of a typical thing. And it really can work quite well. I just had somebody that I saw today. She's been on it for about 6 weeks and she's dropped 8 pounds. That's a little bit more impressive than I would have expected, but she's using that in combination with these other tools and working with a nutritionist, really working on that insulin resistance pathway. And so I see a lot of people with a lot of success, and it's a medication anybody can always get. It's not expensive. It's not restricted by insurance. So it's a really
Mhm.
great idea.
Yeah,
And
that's something I
that's,
use a lot
yeah,
for my patients with PCOS
with
who are having
PCOS, right?
issues
Yeah, yeah.
with
So
weight and
push the
insulin
dose
resistance.
is what I say.
Mhm.
Yeah. So that's a great choice. I use a lot of a medicine called Qsymia as well, which is not one that a lot of people have heard about, but it's a combination of phentermine, which is a mild stimulant that's also used on its own to help reduce appetite, as well as topiramate, which is the medicine that was originally an anti-seizure medicine, but also used for migraines and alcohol use disorder and kind of a lot of different issues. Sadly, the generics by themselves, in my experience, have not been helpful. But when those medicines are combined in these pills, they tend to work really well to reduce appetite, to improve fullness, reduce cravings for food and alcohol a lot of the time. And people just feel pretty good. And I would say we're going to talk about Wegovy, which is Wegovy Ozempic in a minute, but it's actually it was the best that we had before the Wegovy family sort of really became popular. They're really quite effective medications, and people generally feel pretty good on them.
Mhm.
And so I think that is something that we probably need to use more of. It is a controlled substance, so there's a little bit more rules around it. Um, it doesn't tend to be covered by insurance because, like fertility treatments, anti-obesity medications are often outside of the standard insurance coverage, even if you have great insurance.
Mhm.
And so it's often something that your employer has to opt into. But with coupons, it can be about $100 a month, which is more affordable for many people than some of the more expensive medications. And then we'll talk about Wegovy. So
Mhm.
Ozempic and Wegovy are the same medication. So they are one of our GLP-1 agonists, and they work on gut hormones. So Ozempic was first. Ozempic is FDA approved for diabetes, and it's really only approved for diabetes. And so it's very hard to get. It has not been as hard to get for people who wanted it for weight loss, but the pharmacies and the insurance companies are really cracking down on it, and they're actually pulling people off the medications or
Mhm.
refusing to cover it. They won't authorize new prescriptions. Like, they're really starting to get quite strict. And we have this other drug, Wegovy, which is the same medications, semaglutide, and it's FDA approved for weight loss. Because it's an anti-obesity medication, because obesity treatment is not generally covered by insurance, which is a problem, most people don't have coverage for Wegovy.
Mhm.
I'm expecting that to change. I'm expecting more consumer pressure onto the insurance markets to say, we deserve treatment for obesity and metabolic health just as much as we deserve treatments for cancer, for diabetes, for high blood pressure. that's a whole different
Right, because of
conversation.
course that's leading to all of those things, right? It's increasing the
Right?
risk
It's
of all
like,
of those things.
it's so
Yeah.
much cheaper, even at the prices that it costs, to treat us before we get those things. Anyway, we're not
Mhm.
there yet.
Yeah.
But that's the direction that I hope to see us go. But these medicines are working primarily on gut hormones, and they're reducing hunger, they're improving fullness, also called satiety. So people will naturally eat less. They will feel full longer in between meals. A lot of people tell me I didn't really understand what people meant by full. I didn't really know what people were talking about, and now I know. Because now I
Mhm.
definitely feel like I want to stop eating.
Mhm.
And that kind of makes people angry when they realize that, because they realize they've been working uphill, right, against a challenge that not everybody has. But the other amazing things that we're seeing, so if a person has diabetes, it's gonna help lower their blood sugars. If a person has pre-diabetes, it's also going to do that because it's working on sort of the insulin resistance. But also people are noticing less cravings for food and alcohol and even marijuana and probably cigarettes. Like it's just like it's kind of just turned off the interest. Those foods and things are not gross to people. It doesn't make people feel revolted by them. It's just like switching off some of their interests. So they're no longer feeling like, oh, I just, I really want that food, or I really want to drink, or things like that. And that's a
Mhm.
pretty remarkable change for a lot of people. People often find too that it's reducing sort of brain chatter about food, because anybody who's ever dieted, a lot of people will tell me, like I just constantly feel, think about food. And especially when I'm trying to restrict calories, then my food chatter goes up and up and up, right? And I just can't stop thinking about it. These medications help to reduce that. Like they're a real game changer on a lot of different fronts, right? They're more effective at the hunger sort of fullness level. They're
Mhm.
helping our blood sugars. We've got, kind of emerging data that they're reducing heart disease and some of those other important parameters. And they're helping up here, which is really important for so many people, right? Because so many of us who have experienced sort of diet culture and a lot of toxic messaging, right, about our weight and, calories in, calories out, all the things that they've heard for such a long time from the medical community. And they'd love to eat less, right? But they just can't stop the chatter in their brains, right? Or they
Mhm.
just can't cope with that feeling of hunger all the time. These medicines are really changing the story. And I think that we are going to realize that more people are sort of addicted to food than we've
Mhm.
previously sort of acknowledged, right? Medical communities don't want to talk about people being addicted to food because, unlike alcohol, unlike heroin, unlike cigarettes, right? I have to keep eating food to stay alive,
Right.
right? I don't need those other substances. So we can take me off those substances, with my permission or not. I have to keep eating food.
Mhm.
Right, but these medicines are showing, right, that some people really have a lot of strong call to food that not everybody has. And now we can maybe shut it off.
Mhm. So, who are these medications not good for?
Pretty small list, to be honest.
Mhm.
So they have a lot of gut side effects. Well, actually, I should say Wegovy and metformin can have a lot of gut side effects. But those are usually things that get better over time. So if somebody has a
Mhm.
really sensitive stomach, they may need to go even more slowly than usual as we're kind of adjusting these medications.
Mhm.
But that wouldn't be a reason why I would say somebody was off limits. With metformin, we care about the kidneys. And so if somebody doesn't have good kidney function, we'd be very cautious with that medication. It may also be stopped if somebody was in the hospital and they were really ill. But most people are going to be just fine on metformin.
Mhm.
With Qsenia, which is that combination of phentermine and topiramate, can cause kidney stones, glaucoma. People who can't tolerate stimulants, if they can't tolerate coffee, they probably won't be able to tolerate that. It's also a fairly small list of people who can't take that medication. With Wegovy, one of the big carve outs that you'll see all over the website is if you have a family history of medullary thyroid cancer or multiple endocrine neoplasia, right? These very bizarre genetic cancer syndromes. then you shouldn't take it. And that's because mice and rats whom these medications were studied in had GLP-1 receptors on their thyroids. Humans do not. So we've seen increased risks of weird genetic cancer syndromes in mice and rats related to that. It's going to be tracked in humans, but we haven't really seen any changes in the rates, and it will be followed more and more over time. Ozempic, Victoza, some of these other GLP-1s have been on the market for much longer than Wegovy. Wegovy itself is only a couple of years old. But thus far, we haven't really seen increased rates for those cancers. They're already quite rare.
Okay. So yeah, I think that's one of those things that of course, if somebody's obese, and I think obesity medicine is another one of those bad terms because it's really not just about obesity, but about all of these other metabolic issues. So great medications for people who are having those issues. I also find a lot of my patients, especially the ones who are getting into menopause and gaining a little weight, even if it's not a significant amount of weight, even if they were either thin or maybe even underweight to begin with, and now it's just like weight gain for them, which I know stinks. Nobody wants that. But they're like, well, let me look to these medications. Like, is that somebody that you would reach those medications for?
That's a great question. I would have a pretty low threshold to reaching for metformin, especially if I see there's anything kind of in their insulin resistance, kind of pre-diabetes, family history of diabetes, PCOS. I would reach for that anytime that people were sort of doing the right things and not sort of having success. And I wouldn't be too caught up with their BMI, kind of their relative height to weight proportion, because I'm just not concerned about being able to support their goals with metformin. When it comes to these other anti-obesity medications, most of the time you need to have a BMI. I'm going to talk about that in just a moment. BMI of 30 or more, or I think 27.9 plus or 28 plus other metabolic issues. So plus insulin resistance, prediabetes, liver disease, things like that. So I don't use those medications in people who are below those cutoffs. Is it wrong or dangerous? Probably not for most of the people. But is it clearly indicated? No. Are these medications something that you can use quickly to lose weight? No, like that's not how they're designed, because what I didn't get a chance to say yet, right, is these medications are long-term. So they are not, I'm going to go on Ozempic for 6 months and I'm going to lose 20, 30 pounds and then I'm going to stop. You will regain the weight because that's what our bodies are designed to do. And we talked about those metabolic adaptations that are occurring. And so these are long-term treatments. And so when I'm having conversations with patients, that's kind of what we're talking about. I'm not just talking about, let's just try. I think a lot of people are hearing, let's just try Ozempic. Why don't you just go get a prescription for Ozempic? It's not that easy. And we're not just going to slap a medication on without having that discussion about this is a long-term management, right? The same way that PCOS is a long-term condition. Perimenopause, right, is a short-term condition. Short, could be 10, could be 2 years, could be 10 years, right?
Short decade, yeah.
Yeah, right, exactly. And there are treatments that we might use for years, right? Kind of managing symptoms. But these medications are, longer term than that. And so, really having that conversation. So yeah, I wouldn't treat somebody, who, is considered a normal body weight, but they're 10 pounds heavier than they would like to be. These are not what I would play with. And I unfortunately, I think we are seeing a lot of people who are sort of getting them inappropriately in a variety of different ways. There are a lot of compounded products that are out there on the market, which is really actually scary to me because people are walking out of these clinics with like a syringe full of liquid to inject themselves with once a week. No one knows what's in that. I don't know what's in that. Some of the time it might be the real drug. Much of the time, I don't know what's in there. So I really don't.
Very unregulated.
People. Exactly. And we need to put pressure, frankly, on the manufacturers. We need the price to be lower. We need the insurance companies to step up and, allow us to use these medications more often. right? We need better solutions for,
Mhm.
metabolic health, just as we do for perimenopause and menopause.
Yes.
Yeah, but BMI, just to give a little brief discussion. So BMI is problematic in so many ways. It's got racist roots. We can throw some patriarchy in there, right? Like, it's got all kinds of problems. I use BMI and I put people on the scale, not because I want them to get tied to those numbers at all. But when I'm communicating to the insurance company to justify the medical treatment for their condition, when I am requesting medications to, treat obesity and improve metabolic health, I have to use that language of weight and percentage of weight loss and BMI as part of that discussion, sort of with the
Mhm.
insurance companies. So, as far as I'm concerned, I don't think my patients ever need to know their weight if they don't want to. They don't ever need to track themselves on the scale if they don't want to,
Mhm.
because they're doing it for their health. But if I'm using your insurance in order to help support this part of your health journey, I unfortunately still have to use that language, as problematic as it is.
Yeah. Yeah, there are these sort of hoops that we jump over, and sometimes it can help people to have like a little bit of a measure, but right, your end all be all, like,
We
I
want
always
to
laugh
feel
because
good, right? We want to
yeah.
feel healthy. We want to prevent
Mhm.
diabetes. We want to, take good care of our bodies and, go into whatever our next phases of life are feeling good.
Of course, of course. That's always the goal. And I always kind of, so for my patients, friends, myself in perimenopause and menopause, I always say, yes, this stinks. Your body is going through these changes. And I do focus on some of the positive things because I do think, like, there can be a lot of like positive things for your life and like just reevaluating what you want in life that come into perimenopause. But on the weight side of things, I always say there it's changing, it's harder, but there are things that we can do about that.
Yeah.
One of them I always say is acceptance. And that doesn't mean just letting yourself go,
It's
just
not
saying, you know what, I'm
defeat.
gonna gain weight
It's
in
not
menopause.
defeat,
And
right?
yeah, it's not defeat, but it's just the knowledge that, like, okay, my body's not the same as it was when I was
Yeah.
22, and that's
Yeah.
okay. And I have a different definition of what's healthy and what my goals are now. So that's always kind of my first. And then there's always the lifestyle things that make a difference, right? So making sure that you're exercising. So many people like really exercise, or that they'll just start and do the cardio. And I always like, yes, cardiovascular stuff is important for your heart, but
Yeah.
also, that
That's strength
strength
training.
work,
Yeah.
that muscle training,
Resistance.
because of
Yeah.
that loss of muscle mass, because of the metabolism issues.
Yeah.
And then really like looking at the food that you eat, not like so much restriction, but like
Mhm.
the nutrients. There's so much, crappy processed food out there that we're getting that does nothing for our bodies and really like tricks our cells into how they're,
Yeah.
dealing with insulin and how these glucose spikes are going. That, like, the real whole foods, it's like, your
Right.
grandmother
Real
told you, like,
food. Yep.
fruits, vegetables, proteins, like complex
Yep.
carbohydrates, all of those things. And then the sleep and the stress component are really important to kind of broaden that, like I talked about, like that little narrow, like running over the edge. We can broaden that by making sure we're rested, by, doing things that help to manage our stress, by like eliminating the things from our lives that don't serve us anymore and are really unnecessary. And then you do all of those things. And if you're still having trouble, that's where we start to look at medications and stuff like that.
Yeah.
That's kind of
Yeah.
how I look at it. There's not like
Yeah.
a quick fix for this.
They're not a quick fix. And I talk about them as being a tool in the toolbox, and they're probably a
Mhm.
tool that more of us would benefit from. And again, because of a lot of reasons, right? We haven't had those conversations. I think the understanding, not unlike perimenopause and menopause, has not been there on the medical side because we received very little training on how to help people with weight problems.
Mhm.
But now as we start to learn more and do more, I hope that we will be better at having, appropriate conversations with people about those basics that you mentioned, as well as offering them the options of, yeah, there are some people that are going to benefit from medications. Yes, there are some people who are going to benefit from surgeries. We need to offer those as options in conjunction with all the other stuff, right? I don't think of either medications or surgery as replacing those things. They are tools to use alongside.
Definitely. So no quick fix. And
No quick
yes, it's
fix.
difficult to get into these conversations. It's difficult for people to make the changes. It's
Mhm.
difficult to do in our current medical system where we're limited time for
Yeah,
visits. That's why I
exactly.
love that you're doing this and putting information out there that people can really see, like, okay, what am I doing, and reevaluate and what might work for them. So I love it.
Yeah, yeah, thank you. And I love having these conversations, right? Because bringing, kind of our two worlds together, because, we both take care of, conditions that have historically been undertreated. We are choosing to stand up and tell, kind of the truth about, what we've learned, what we've experienced as part of our personal health journeys, as well as our experience of our patients. And we need more of that, right? Because if we're going to disrupt all the problems with the American healthcare system, it's going to take people like us standing up and saying, what we have is not sufficient to address the needs, medical and otherwise, right, of the patients that we
Hmm.
serve. And so I thank you for coming on and giving us your time today so that we could really sit down and sort of dive into the conversation that I think more people need to have access to.
Excellent. Yeah, I really appreciate it. Thank you so much for having me.
Yeah. So I'm going to share your contact links with everyone so that they'll be able to find you, but just briefly kind of mention where people who are watching can learn more about you and your practice.
Yes, so my practice, I'm at the Florida Center for Urogynecology, which is in South Florida in Hollywood. So floridaurogyn.com for that. And then I'm on social media under Enrich. So my name is Ritch, Ritch. So it's ENRITCHED. That's my TikTok, my Facebook, my Instagram, and then my podcast is Enriched Menopause, spelled the same way.
Awesome. Awesome. So go follow Dr. Rich there. Come, listen to her podcast and learn all the things. Um, and until next time, thank you so much for watching.
Thanks, Megan. Bye.